I'm Dr. Fakir Raveri, and this is upper respiratory tract infections and influenza in adults. Respiratory tract infections are generally divided into upper and lower. Upper respiratory tract infections include common cold, otitis, pharyngitis, and rhinosinusitis. Influenza can be uncomplicated, which typically affects the upper respiratory tract, or it can be complicated, which affects the lower respiratory tract. Now let's take a look at influenza. Influenza is an acute febrile respiratory illness caused by the influenza viruses. In temperate climates such as the United States or North America in general, it typically occurs every winter. And it actually happens year-round in tropical climates. The flu season, for the most part, it's approximately between November to April in the US. While influenza has existed for at least the past 400 years, it was actually isolated in 1933. So the influenza A was the first that was discovered, followed by influenza B and C in 1939 and 1950. And then in 1936, we had a huge discovery that influenza virus could be grown in eggs, which gave us the ability to develop vaccines against influenza. Now let's take a look at influenza virology. The influenza virus is classified into three distinct types, which are called influenza A virus, influenza B virus, and influenza C virus. Influenza A virus can infect humans and other animals such as birds and swine, and it is the most severe and widespread disease. Influenza B can only infect humans, and it can cause severe disease, usually in elderly or high-risk patients. And influenza C can infect humans and swine, and it is rare cause of mild upper respiratory tract infections. So because it's a mild upper respiratory tract infection, there's typically no treatment. Patients will just naturally clear it. Now, both influenza A and B are subject to antigenic drift, which are basically point mutations that happen in the genetic material of the influenza virus, and this leads to variation that can cause epidemics every influenza season. Now, influenza A is also subject to antigenic shift. With antigenic shift, the variation is so much that actually a new strain of the virus is introduced, which can cause global pandemics. And this typically does not happen with influenza B. And of course, influenza C can infect year-round, unlike the seasonality of influenza A and B. Influenza virus is an enveloped negative sense single-stranded RNA with segmented genome, meaning that there are multiple RNAs inside the virus. Hemagglutinin, abbreviated H or HA, is a viral attachment protein, which you can see. So in this picture, I'm showing you influenza A specifically, and this is hemagglutinin. And there are at least 16 distinct hemagglutinins in influenza A. There's also neuraminidase, which is abbreviated N or NA. And neuraminidase is an enzyme that catalyzes the removal of terminal sialic acid from sialic acid containing glycoprotein. And I will explain what this actually means when I show you the life cycle of the virus. Another name for neuraminidase is sialidase. And the reason this is important to know, because we have a class of drugs called neuraminidase inhibitors, and sometimes they're referred to as sialidase inhibitors. And something that's specific to influenza A only is the M2 protein, which is basically an ion channel, which you can see here. This does not exist in influenza B. Now let's take a look at influenza nomenclature. So the standard nomenclature includes the influenza type, so it's either A, B, or C, and then they put in the name the place of initial isolation, followed by strain designation, year of isolation, and if in the case of influenza A, it also divided into subtypes on the basis of H and N. So, for example, the influenza A virus that was isolated by Francis from a patient in Puerto Rico in 1934 is given the strain designation A, Puerto Rico A834. And then a more recent example is the pandemic H1N1 influenza A virus first identified in April 2009 in a 10-year-old patient in California, which has the designation A/California/7/2009, and then in parentheses, because this is A, we have H1N1. In 1934 they didn't have the molecular capability to type H and N, so that's why the 34 from 1934 doesn't have it. But in modern era we have the molecular capability to type H and N. So this is the H1N1. Now let's take a look at influenza transmission. The influenza virus actually has the ability to spread very efficiently from person to person through 3 routes. So one route is by aerosol, which are basically the fine particles that remain airborne for minutes to hours, which basically comes from a donor or an infected patient, and they can be inhaled. And because they are so small and fine, they can actually go deep into the lung. And because they go deep into the lung, they can cause lower respiratory tract infection. They can also be in the form of droplets. So because droplets are large particles, they typically don't go too deep into the lungs. So if someone gets influenza by droplet, they end up having upper respiratory tract infection. And of course, by contact transmission from fomite. So fomite is an inanimate object that's been contaminated by the virus, and once there's contact with the mucosal surface, that's how patients get infected. And typically, because the virus can actually last up to 48 hours on these surfaces. Now let's take a look at pathophysiology of Rhino sinusitis. The paranasal sinuses are 4 paired air-filled spaces located between the orbits and below the anterior cranial fossa, and they are frontal sinus, maxillary sinus, ethmoid sinus, and sphenoid sinus. And just like the rest of the respiratory tract, these sinuses are actually lined with ciliated secretory respiratory mucosa. Now these sinuses actually drain through narrow ostia, which are several millimeters in diameter, and are actually prone to obstruction when the mucosal lining swells in response to viral infections, for example, or environmental irritation. Rhinosinusitis is typically caused by inflammation and mucociliary dysfunction from either viral infections or allergies. There can be increased mucus production as well as reduced clearance, which can lead to obstruction of the sinus ostia, which creates a great environment for bacteria to grow. As a result, the immune response will cause inflammation, and there can be damage to the host local defenses, which can actually further promote growth of organisms. Risk factors for rhinosinusitis is allergic rhinitis, nasal polyps, which can also cause obstruction, asthma, cystic fibrosis, and immunodeficiency, as well as environmental factors. Now, occasionally rhinosinusitis can result in complications, and the site of these complications include the orbits, so the eyes, and also the nervous system. And that makes sense because these are in proximity to the sinuses. So if the infection gets complicated, the organism can actually penetrate the eye and also the brain. When it comes to pharyngitis, the mechanism is actually not well understood. It's proposed that alterations to the host immunity actually allows for organisms to grow in the pharynx. Although pharyngitis for the most part occurs in children aged 5 to 15, it can also occur in adults, especially in parents of school-age children, because pharyngitis is contagious. Pharyngitis is basically the infection of the pharynx, which is basically the throat. And when it comes to streptococcus pyogenes specifically, so when pharyngitis is due to streptococcus pyogenes, because viruses can also cause pharyngitis, streptococcus pyogenes so basically can
penetrate the epithelial cells in the throat, and if they find their way into the blood, that's when the immune system will be activated. So specifically, macrophages will basically absorb these streptococci, and then as antigen presenting cells, they will break this down, and in collaboration with the T cells will present this to the B lymphocytes, which in turn will actually make antibodies against these streptococcus species. Now the problem is there are proteins in the heart that look similar to these antigens that come from Streptococcus pyogenes. So when the immune system have immunity against this strep, it can actually in the heart, these antibodies can start attacking the myocardium and the valve tissue, which in time can lead to heart disease.
Let's take a look at some reliable resources. So we do have a 2012 IDSA guideline for acute bacterial sinusitis. We also have a 2012 IDSA guideline for group A streptococcal pharyngitis. There's also a 2015 guideline for sinusitis from AAO HNS, which we will not talk about in this topic. And there are also guidance available from the American College of Physicians and the CDC on acute respiratory tract infection in adults. Lastly, IDSA has a 2018 guidelines for the treatment chemoprophylaxis of influenza. The first learning objective is describe the influenza life cycle and the mechanism of action of endonuclease and neuraminidase inhibitors. Now, when we look at the life cycle of influenza virus, it's important to know that endothelial cells of the host have receptors that are rich in sialic acid. So hemagglutinin on the envelope of the virus will actually bind to those sialic acid containing receptors. Once bound to the host cell, the virus will enter the cell through endocytosis, and as the pH drops inside the cell, the RNA material will be released into the cell, as shown in orange, these orange bars. Now, as I mentioned earlier, the influenza virus is actually a negative sense RNA, and that means that a negative sense RNA is not ready to just find a ribosome and translate into protein. What it needs to do is to first translate into positive sense RNA, and then a positive sense RNA will be ready to find a ribosome and translate into protein. So what these negative sense RNAs need to do is to enter the cell, and then using the RNA-dependent RNA polymerase, make a replica of these negative sense RNA, which are shown as blue bars, and those blue bars will actually be positive sense RNAs. Now, this process is extremely important to the life cycle of the virus, and we have drugs that can actually target the RNA polymerase. So we have ribavirin that is actually an RNA polymerase inhibitor, but it's not commonly used for influenza. And we have a new drug called baloxavir. Baloxavir is an endonuclease inhibitor, so it selectively inhibits the cap-dependent endonuclease activity of the influenza RNA polymerase. So by inhibiting this RNA polymerase, it results in inhibition of mRNA synthesis, so it will interrupt the the life cycle of the virus. Once the mRNA is synthesized, it will go to find a ribosome and translate into protein, and those protein products, along with some of these mRNAs and some of the the RNA material of the virus, will basically assemble into a virus. The final step is the release of the mature virus, and because again this hemagglutinin is bound to the cell receptor through sialic acid binds, actually needs sialidase, or another name for it is neuraminidase, to actually cleave that bind to let go of the virus. So because that sialidase or neuraminidase is extremely important for the final step of releasing the mature virus from the host cell, we have a class of drugs called neuraminidase inhibitors such as oseltamivir and zanamivir, which actually prevent the release of newly synthesized virus from from the host cell by inhibiting sialidase or neuraminidase. Now, we currently have 3 drugs on the market under neuraminidase inhibitor class. So the first one, which is the most commonly used, is oseltamivir phosphate. So it's a prodrug. That's why you see phosphate in the name. The brand name is Tamiflu. It's available as a capsule and in suspension form. And for treatment of influenza, we typically use 75 milligram PO twice a day for 5 days. You can also use it for chemoprophylaxis for preventing influenza. Note that the dose is just once a day, and it is renally cleared, so the dose needs to be adjusted if the creatinine clearance is less than 60. It is pregnancy category C. However, Tamiflu, or I should say oseltamivir, is preferred in pregnancy because it has relatively more data compared to the other drugs in this class. The second one is zanamivir or Relinza, which is actually an inhalation. I have posted a video for on how to administer these inhalations, and I encourage you to watch this video. One thing that's especially important about Relinza is that it actually has lactose in it, so it's contraindicated in patients who have allergy to milk protein or lactose. Also, because it is inhalation, the systemic absorption is minimal, so there's no dose adjustment needed. The last drug in this class is Pramivir, which is actually an intravenous formulation, which you can just give it once. Now, the most common adverse effect with all of this is basic gastrointestinal, such as diarrhea, nausea, and vomiting. Oseltamivir can also cause headache, and of course, zanamivir is inhalation, so it can cause bronchospasm. Now, recently, Baloxavir or Xofluza was FDA approved. It is an oral formulation that's available as a tablet or a suspension. Note that the dosing is based on body weight. So if someone, including children over the age of 12 years, weigh less than 80 kilos, 40 milligram, a single dose is recommended, whereas anybody over body weight 80 kilos or higher will require a single dose of 80 milligram. It is also a single dose, same recommendation for chemoprophylaxis, so it's convenient that it's just a single dose and no dosage adjustment is needed. Some of the adverse effects include GI, bronchitis, and headache. And one thing to note is that it is active against oseltamivir resistant strains and avian strains, which generally are not common, these strains.